A kidney transplant kicks off a lifelong war against the patient's own immune system. The enemy is that system. The key is HLA-DR matching. Think of these as cellular ID cards. The closer the match, the better the graft's survival. But even with a perfect match, rejection is a constant threat.
Know the timeline. Hyperacute rejection hits in minutes, preformed antibodies.
Acute is weeks to months, driven by T cells. Chronic is the long game, a slow fibrosis over years.
Our shield? Calcineurin inhibitors, like tacrolimus, they suppress T cells, stopping the attack.
Let's go! This content is for educational and board review purposes only. It is not a substitute for clinical medical advice. Always consult official guidelines and a specialist for patient care decisions.
All right, Sarah, let's put this into practice. A kidney transplant is truly the gift of life, but the challenge begins immediately. We just covered the timeline of rejection, so let's start at the beginning. A surgeon connects the new kidney, and within minutes, it turns dark and dusky on the operating table. What's happening?
That's the dreaded hyperacute rejection, Dr. Collins. It's happening in real time, caused by preformed antibodies the patient already had, triggering a massive type 2 hypersensitivity reaction. And in this scenario, well, the graft is lost. The only option is immediate nephrectomy.
Exactly. But the scenario you're far more likely to face, both in the clinic and on your board exams, is this. Your patient is 3 weeks post-transplant, and their creatinine starts to rise. Now, the big question is, what's the cause?
And that truly is the billion-dollar question. Because on one hand, that rising creatinine could signal acute cellular rejection. The T cells are attacking the graft. But on the other hand, tacrolimus, the very drug we're using to stop rejection, is nephrotoxic. It can harm the kidney itself and cause the exact same lab finding. So how do you tell the poison from the attack?
There's only one way to know for sure. You have to get tissue. You must biopsy, Dr. Collins.
Precisely. The biopsy tells the whole story. If the pathologist sees tubulitis, and that's literally lymphocytes invading the kidney's tubules, the diagnosis is rejection. Your treatment is high-dose corticosteroids. But if that biopsy is clean and the patient's tacrolimus level is high, you're looking at toxicity. The treatment there is the complete opposite. You have to carefully lower the dose.
Right, and this just nails that delicate balance we're always walking. Too little immunosuppression and you get rejection. Too much and you risk toxicity and opportunistic infections. So here's our question for you. Have you ever cared for a transplant patient with a CMV infection? Let us know the classic signs you'd look for in the comments below.
Excellent. You've navigated the diagnostic challenge perfectly. Now let's lock in these key associations with a quick review. Ready for the immune duel, Sarah?
Ready, Dr. Collins.
Hyperacute is minutes, caused by antibodies. Acute is weeks, driven by T cells. Chronic is years, leads to fibrosis. And the key biopsy finding, tubulitis, means rejection. Time for steroids.
The immune battle is won. But if you can't integrate the entire failure algorithm into a single decision tree, you aren't exam ready. Watch the master finale now.